managed to go take that case of CA alveolus, third year student. Went down to the OPD, found the patient, CA alveolus, presently. First thing was IO Banerjee, alveolus is inside the mouth. So, the entire history changed, presentation changed. Many other teachers would probably have lost their cool. He didn't. He went on to teach. And that is the nature I saw later on also. When I saw him working, he came in very simple clothes. Sometimes you wouldn't even understand he is the associate professor in the department. Very caring for the patients. The bonding was amazing. He was very close with the non-teaching staff as well. And finally, sir went and joined KSAGDE. But we were in constant touch. Even on the day he expired, we saw his messages in the group at 5:34 p.m. By 5:45, everything was gone, difficult to digest. I only pray that his soul attains eternal peace. Thank you.
One of the most sincere person I have ever seen, never show off whatever he was inside as well as outside. Very, very simple person. Of course, we didn't have much professional relationship, but then we had a very good respect to each other. He was, of course, my junior, but a wonderful man. Last time I met was in Kanachuru Cancer. They had some memorandum of understanding between Kanachuru Institute and KSAGDE about radiotherapy. That is the time I was speaking to him for a long time, and I never expected that this kind of things, would have happened so early to him. He was a man looking so fit and energetic, unlike me, where everybody suspected that I will be having soon some IHD or something like that because my obesity and so on. So I was really surprised as to how a person of this sort who has been always working and a man with high spirits, never took any of this business very seriously, never took stress to his mind, but really we don't know God's way of making things end. It's in his hand. And we always pray that his soul rests in peace. Thank you so much.
I request members to please move forward and play the floral tributes to Sir.
Bhagavan Sri Krishna's words are there in the Bhagavad Gita. Nainam chindanti shastrani, nainam dahati pavakaha, na chainam kleda nyapo, na shochayati marutaha. The soul cannot be cut by knife or sword. It cannot be burned by the fire. It cannot be made wet by water, or it cannot be dried by air. So, IMA Mangalore branch, we place on record the condolence message. The President Executive Committee members pray Almighty to give strength to bear the irreparable loss and convey the deep condolence to his family members, relatives, and large number of well-wishers on this day, 13 January 2023. Om Shanti.
I think for me, Jairam Shetty sir was a teacher, and he was always a well-wisher who was always there, and it's a big loss for all of us. I think just one day prior to the what happened, I had sent him the invite for this today's event, and he had, as usual, sent the thumbs up. A very, very God-loving person, and I'm very sure he's up there with the God blessing us. And I request all of you to please stand in 1 minute.
Good evening to one and all present here. I would like to welcome the August gathering for the monthly CME of IMM Mangalore for the month of January 2023. I would like to request Dr. Venugopal, President, Dr. Achuth, Secretary, and Dr. Nandakishore to accompany all the speakers to the dais. Today, we have with us Mr. Rohith Rao, Dr. M. Vijayakumar, Dr. Senthilnathan, Dr. Achuth Nayak, and Dr. Rajesh Krishna speaking for us. I would now request Dr. Venugopal, President, IMM Mangalore, the man behind all the meetings, to address and welcome the gathering.
Very good evening and welcome to this event, IMA Mangalore branch. This is our second meeting this year. Wish you all of you a happy new year and also in advance happy Makara Sankranti. Congratulations to Dr. Pradeep Senapati, who has awarded Man of the Series award in recently held cricket tournament in Shivamogga. Senapati is here. And also congratulations to our one of the senior members, Dr. Mohan Chandra Swarna and Madam Sujata Swarna. His son got married on the 1st of January this month. Siddharth married to Pallavi. So we wish the new couple happy married life. So this evening we have two events. One is purely non-academic, other one is academic event. So on the non-academic side, we have with us Dr. Rohith Rao, who is well known in Dakshina Kannada, not in medical fraternity, but as a multifaceted personality. And he is going to give us an idea what is emergency communication. When all the communication fail, what matters is emergency communications. He is a amateur radio operator, enthusiast, and is actively involved in a lot of activities in amateur radio. I request Dr. Ranjan, he will briefly give his CV. Now coming to the academic event, we have with us Dr. M. Vijayakumar, Professor of Oncology and Vice Chancellor of Yenappaya Deemed to be Universities. Medical fraternity knows him very well. He was a well-known figure in the oncology, and his biodata to read, it runs in pages. He has received numerous awards. He did his MBBS from Madras Universities way back in 1979, then National Board of Examination in General Surgery in 1985, and MCH from 1993, and FRCS in 2007, FICS in 2019, and he joined Kidwai Memorial Institute of Oncology in Department of Surgical Oncology as a resident in 1984 and ascended to become the professor and head of the department. And he took a voluntary retirement in June 2015 and he joined Yenappaya Medical University, and he was the director earlier also in Kidwai Memorial Institute of Oncology. Apart from all these awards and publications of a lot of papers, what matters for us in Mangalore is he is instrumental in bringing the Tata Memorial Cancer Institute to the doorsteps of Dakshina Kannada people, I can say. It is the Tata Trust who has built a beautiful building, cancer management, and provided with the equipment, state of the art. The more important is these facilities are available with the affordable price. That is the most important thing, and the entire credit goes to Professor M. Vijayakumar. So he is going to give us overall cancer therapy, overall management of cancer therapy, and followed by we have the radiation therapy oncology will be dealt by Dr. Achuth Nayak, MBBS, MD, DNB Radiation Oncology. Is an assistant professor of radiation oncology, and his resume, he has finished MBBS from KMC in 2006 to 2011, MD Radiation Oncology from Tata Memorial Hospital, Mumbai, and he worked as a senior resident in the same institute, and he was a consultant later in Radon Cancer Center, Hubli, and currently working as an assistant professor in Edampaya Medical College, Mangalore. We have nuclear medicine specialist Dr. Senthilnathan. He is MRCP, FRCP path. He is MD nuclear medicine and a consultant nuclear medicine specialist in Edampaya deemed to be universities. So he is going to talk on nuclear medicine in oncology. What is the importance of nuclear medicine in oncology? And Dr. Rajesh Krishna, he is a hemato-oncologist. He has been, ever since he has came to Mangalore, he is well known in the Mangalore medical fraternity. He is a consultant hemato-oncologist in Edampaya deemed university. He did his MBBS from Calicut Medical College. Then he moved to UK for his training in medicine, and later FRCP path and CCT in hematology. So he is the first hemato-oncologist to carry out bone marrow transplantation in lymphoma patients and pediatric patients in this part of the country. So with this, I would just want to mention that whenever there is a Sanskrit Subhashita which says that the knowledge what you have cannot be shared with your brothers, it cannot be, as you teach, it keeps on increasing, the knowledge keeps on increasing. The government cannot put tax on that. There's a the knowledge is the one thing which, as you share, you gain, keep on gaining it. So today, these medical doctors, the consultants are going to give us a lot of insight on this cancer management, and it will help a lot for our members to in their day-to-day practice. Thank you very much for the patient here.
Thank you, sir. I would now like to request Dr. Ranjan K, President-elected, to introduce the first speaker for today's evening.
Good evening, friends in IMA, and I'm here to introduce my good friend, multifaceted, talented. If you ask me, he has gone into all the whatever field that we all know is his choice. Before that, I welcome Mr. Vishnumurthy, the president of Mangalore Amateur Radio Club, to our meeting. Mr. Rohith S. Rao is a friend of my friend, Mr. Sumit S. Rao, who is associated in Rotary Club. So that's how I came to know about him. And when I appeared for the Mangalore Amateur Radio Club examination in 1992, when I passed my exam, that time I came to know more about him. Today I'll just introduce him briefly. His biodata is actually lengthy, but I'll cut short and present it to you. He's a proprietor and Chief Executive Officer of Crystal Electronics and Appliances in Balmata Road. It is an exclusive LG showroom. He has done his education in St. Aloysius High School, St. Aloysius College, and completed his MBA at Mangalore University, Konaje. He is an active member of Radio Ham. He'll tell more about it. He was ex-president also of this club, Mangalore Radio Amateur Club. We call it MARC. He is Assistant District Commissioner for Bharat Scouts and Guide, Dakshina Kannada. Friends, I like to tell him that he is an active in Scout movement. Of late, if you know the Jamboree that held in Mudabidri, he was the chief coordinator for such a big gathering there. He also set up a ham station there. And all of us in the Mangalore Amateur Radio Club enjoyed the activity there. He is a founder, member of Amateur Astronomers Association Mangalore, and he also was managing trustee of Kudremukh Wildlife Foundation, a conservation NGO. As I said, that he is an active member of a radio club. In his college days, he was an active in debating societies, conducted many quizzes, conducted many experiments in science, and also won many awards in the same group. He has been awarded the President Scouts Award, and even now is very active in the Scout movement, as I said. His interests are traveling, motorsports, wildlife conservation, wildlife and nature photography. See this, he's a photographer. I have attended his class on photography, fantastic, wildlife and nature photography. He has stayed for hours together to take a glimpse of that animals, whatever he was waiting for. And with an avid trekking, he has gone to all these, the neighboring woods, also Himalaya. I listened to that talk also. And he is interested in camping, amateur astronomy. If a solar and lunar eclipse come, he is a very active member. And he has got his own lab at St. Aloysius College, and many public are invited to show his excellent activity in that astronomy world. He is in ham radio and loves motorsports and reading. He is married to Sukanya, who is also a ham member, and blessed with son Abhi, is also an ham member. So with this brief introduction, I like to introduce Rohith S. Rao to the August gathering. He will tell something about emergency communications. And if you ask me what it is, it's a hobby, that's all. It's a hobby. You can pursue anywhere in that field, anywhere, because I am not even 10% of what he is doing in ham. That's why I called him. So thank you members.
I would now like to request Mr. Rohith S. Rao to enlighten us on matters of emergency communication.
Honorable President and the office bearers of the IMA, doctor friends, my own friend Vishnumurthy, the President of Mangalore Amateur Radio Club, and all other friends. A very warm good evening to all of you. Now I just want you all to switch off from the mundane life which we lead, our professional lives, or all our humdrum of daily routine, and just think that you have to talk and make friends with a lot of strangers. Just imagine yourself sitting at home and talking to an astronaut who's rotating around the world in the International Space Station. Now just imagine you're sitting at home and talking to an explorer who's exploring the Antarctic, or a doctor who's rushing to a surgery but still has the time to say hello to you, or a teacher in a small island in the Pacific. Just imagine this. Is it possible? Yes, it is. All this is possible via this beautiful hobby called ham radio or amateur radio. You would have heard of ham radio in various forums, but might not have had a very good idea exactly what ham radio is all about, and who are these people who are called as hams. Are they really pig-headed people? No. Hams are very interesting people, and hams are all around the world. So in brief, ham radio is nothing but a beautiful hobby, an interest which everybody has in communications, maybe in electronics, or just a hobby where you can make friends and also give back to society. So these are some of the very broad facets of ham radio. So who founded ham radio? Really, nobody has the answers, including all of us hams. Ham is not even an acronym, an abbreviation, but somehow people have fitted some abbreviation to it, and they call it with the scientists who are connected with radio technology, Hertz, Armstrong and Marconi, maybe. But still, hams are just enthusiasts who want to experiment with radio communications. So radio communications might have begun right from Hertz and Marconi, who are experimenting with electromagnetic waves, radios. So today, the importance of communication, you know how important communication is. And every single communication today happens through radio waves. Believe it or not, when we say radio, I give this talk to even children, and many a times I ask them, have you seen a radio? Do you have a radio at home? And you won't believe it. 80% of the time they wouldn't have. They wouldn't even know how a radio looked like. But I'm sure this audience would have listened to your regular radio, the receiver radio. What we are talking is not just a receiver, but we are talking about a transceiver. What I have in my hand is the most simple transceiver. What you have in your pockets is a very complicated transceiver, but both are transceivers. A device, this is also a transceiver. So a device which can transmit and receive is a transceiver. So a lot of you may ask the importance of ham radio in today's society when you have already a wireless device. Every person has a wireless device in his pocket. Many a times I get students, youngsters, the teenagers saying, what is the use of this age-old, good old radio? Looks so bulky and ugly. Well, you have the most advanced system in your hand. So the difference is very simple. This is a very simple transmitting and receiving device. This device is an incomplete device. Can you tell me why? Anybody? The difference between this and this. This does a very less work. This won't give you apps and this won't give you a lot of things. But still, this is an incomplete device. I mean, this is an incomplete device. This is a complete device. I'll give you the answer. Very simple. This is only part of the system of communication. This system relies heavily on others. So there is a back-end person or back-end equipment, a hoard of equipments which is invisible to you. Of course, one thing which is visible is all the ugly towers all around the place. The towers are the most important thing for your communication. So it is dependent on towers. Beyond towers, there are huge electronic exchanges. If somebody has really seen the old electronic exchange, it was so difficult in the earlier days. You remember how we used to place calls, trunk calls. So there used to be a manual person with what you call wires connecting you to one person and say, okay, please hold on, I got this fellow on the line, and then plug it in and all. Today everything is automated, but still your mobile phone is heavily dependent on a system which has to support you, a huge system. Now when you have friends abroad, so easily you will transmit data. So for you, I mean, it's very easy for anybody to think. Of course, the technology is huge. So your signal goes from your place to a tower to an exchange. Then it goes through OFCs, optical fibers. It reaches some shore. From the shore, it goes undersea, goes back to the target place, and again reforms the same way. So it's heavily dependent. Now what about this? Not dependent. This is a complete transceiver. If I have one set like this here, and my friend Ranjan has another set, we can talk to each other. And that is where I come to emergency communications. So what are hams? Simply anybody in this world. It's an international hobby, mind you. It's got heavy membership, or rather people who follow ham radio, and anybody in India who is above the age of 12 years can qualify as a ham. Anybody. The only criteria is there is a small exam conducted by the Ministry of Communication. You have to answer that exam. You have to pass it. There is some verification by the police and the authorities so that they filter out unwanted people using these devices, and you have a license. You will also get a call sign. A call sign is one which you identify yourself, or rather the entire ham community in the world identify you as this particular person. So you would have flown in airplanes. At the tail of the airplanes, have you all seen the letters V and T? V and T. VT stands for India actually. Same way for ham radio operators or radio operators, VU. Victor Uniform we call it. VU is the prefix that is given to our license, or the call sign. We call it call sign. So it's like my call sign today is VU2RDQ. Victor Uniform 2, Romeo Delta Quebec. That's how. And this is a very unique call sign all around the world. We have a directory, so anybody whom I am talking to can identify who I am just by looking at it. So similarly, Dr. Ranjan, his call sign is VU2AXB, Alpha X-ray Bravo. So these are the call signs. So what do hams basically talk? Hams basically have a lot of banter around. So we are just friends, just like how you would call your friend and ask something. So we talk a lot of things. We talk technical. Basically, it's a technical hobby. I'll call it threefold. So we have interest in this particular radio communication as a hobby. So we talk a lot of technology-based things with each other. So since this is an open hobby, we have everybody in this particular hobby. There are engineers, there are doctors, there are scientists, there are ministers, prime ministers, there are kings, queens who are hams. So you get to meet a plethora of people around the world, and you can talk to them sitting at home. That's the beauty of this hobby. So we talk technical. We also make beautiful friendships throughout our age. If you are a very young ham, maybe till you die, you will have hams. We used to have some real old hams, and they have been fostering so much of friendships around the world. And the third important thing is your contribution to society as emergency communication provider. So in emergency communications, what happens is basically your mobile phones fail. Obviously, when there's an earthquake, your towers will go down first, power will go off, so there will be a power outage. After some time, there won't be any communication or any power to support your entire system, which I told you, the backbone for this particular communication system, your mobile, it will fail. Then hams come to the rescue. So hams can set up a station, a radio station, a transmitting radio station in 15 minutes flat. If a ham knows exactly how to communicate, the technology used, he can be up and running in 2 minutes. If I have a set like this, if somebody else has a set like this, we can communicate. The range depends, that's why we learn the technology. The higher you go, we get signals farther. So what happens is, when there is a failure of basic regular communication, hams go and step in. So we set up stations in various places where there is a calamity. Suppose there is an earthquake. In Bhuj, there was an earthquake in Gujarat. So during that time, all communication just flopped. In Orissa, there was a cyclone. Nothing was working there. And people didn't know whom to communicate. So hams went there, set up a station, set up another station in the district headquarters, or whoever is coordinating the rescue, and they could communicate with each other. The first intervention is very important in a disaster. So if disaster prone areas already have hams, they can easily communicate with each other. So hams do provide human services to the district administration, to the nation, in case of many of the disasters which has happened, which may happen in future. So it's wise that we foster this hobby, we encourage this in schools, and since anybody, you yourselves, anybody, whatever age, you can become a ham. It's as easy as that. Okay, so this is in a very small, brief nutshell I've given you, since I have just about 20 to 25 minutes. I've packed many things in very concise thing. You can always ask me, no problem. But more, instead of just talking, I'll just give you a small demo. So we'll just see. So we have a very small set. We call this a VHF set. You would have seen it with all and sundry. I don't know, in most hospitals also today, people are using. Gone are the days when you have your regular beepers and pagers, but still I heard pagers are still used. Is it in hospitals now? No, pagers are not used. Okay, I think in abroad, most of the places pagers are still used. In US I've heard. So anyhow, so this thing is a simple VHF device, a wireless walkie-talkie. So how we communicate, what exactly we talk, we'll just have I'll just give you a very small demo. Just listen to our banter, how we talk to each other. Let's see. Yeah. Any station on frequency. This is Victor Uniform to Romeo Delta Quebec, calling from the Indian Medical Association meeting hall. Any station on frequency, VU2 RDQ here, over.
VU2 SBJ. VU3 FES, VU3 Foxtrot Echo November.
Okay, wonderful. So I have two people who are already on the frequency or on the air. So he identifies himself as Victor Uniform to Sierra Bravo Juliet, SBJ, and another person called VU3 FEN, Fox Echo November. So we'll just call them. Victor Uniform to Sierra Bravo Juliet. Please come in. This is VU2 RDQ. I just want you to introduce yourself, your location, and what exactly you do. So back to you, VU2 SPJ, VU2 RDQ.
Okay, good evening, Rohith, and good evening to all my other friends who are listening to you at the IMA meeting hall in Mangalore. My name is Srikanth. My handle, as we refer to, or name for short that friends on the radio call me, known as a handle, is Shri. And I'm talking to you from Manipal, not very far away, just about 60-65 kilometers. And my call sign or my identity on this radio is VU2SBJ, and phonetically to spell it out, it is VU2 Sierra Bravo Juliet. I took up this hobby in 1992, got my license in 1994, and professionally I am an electronics engineer. So there is some little bit of association with the hobby, which need not be, but apparently it does for me. And that's a brief introduction about me. Back to you, Rohith. Very nice to know that you are introducing this wonderful hobby to others around you in Mangalore. VU to RDQ, VU to SBJ.
Okay, Victor Uniform 2, Sierra Bravo Juliet, VU to Romeo Delta Quebec here. Yeah, thanks Shri there for introducing yourself and telling who you are, from where you are. Wonderful, and thank you so much. I'll pull in Sukumar there. Sukumar, you can come in. Be very brief, Sukumar.
Roger, good evening to you to RDQ, Old Man Rohit. This is the good evening to you to SPJ. This is the 3 Foxtrot Echo number returning. Good copy from both of you. And friends at the IMA meeting, I want to introduce myself as Sukumar. I am from Kottara, Mangalore. I am a retired banker, retired from services of Canada Bank. Now I am working as auditor. I am a 73 years old man. I took up this hobby in 1994, attended classes, got the license in 1996, and came on the air in 1999 after acquiring a radio set. 2000 rather, at the end of 1999, beginning of 2000, I came on the air. I am enjoying. So for the last so many years, I have been in this hobby, and thank you very much for calling me VU to RDQ. I think this is enough for me. Go ahead, VU to RDQ. This is E3FTN. Over.
Okay, Roger. Victor Uniform 3, Foxtrot Echo November. Sukumar, VU to RDQ here. Yeah, thanks for that brief introduction and lovely demo. And I think most of the doctors could listen to you, and yeah, they got that you are a very young person of 73 years old and following this particular hobby very ardently. Thank you, Sukumar. 73s, bye-bye. And if there are any other callers, I just want one sentence from each. If there's anybody, just pop in and say hello to all the doctors here. This is Victor Uniform 2, Romeo Delta Quebec, standing by.
Fox Delta Uniform, Rohith.
Okay, Fox Delta Uniform, you can come in. Be very brief. We don't have much time, Ashwin. So go ahead.
Okay, to RDQ, Rohith, good evening to you and all your friends there, and all the doctors there listening to this conversation on the radio there. My name is Ashwin, 3 Fox Delta Uniform, located close to the Mangalore railway station. Good evening, not take much of a time, just a demo for the radio. Earlier, 2 of my colleagues have already spoken to you all. Nothing else, Rohith, have a wonderful evening, good night for now. 3 Fox Delta Uniform, QS5.
Thank you very much, Ashwin. 3FDO, 73s. ABU, are you there?
Roger.
Yeah, you can go ahead and introduce yourself. You will be the last person there. Just go ahead.
Okay, good evening, Rohith, and good evening to all the doctors who have assembled there at the IMA meeting in Mangalore. My name is Abhay Hegde, and I am speaking to you from Hat Hill, Mangalore. I've been a ham since around 1980. Nice seeing all of you. Good job, Rohith. I hope you'll be able to add a few more doctors into our hobby. Go ahead, Rohith. Thank you. 73.
Okay, lovely there, Abhay. Thanks for that very brief communication. So 73s and good night. So thank you all, Shri, Sukumar, Ashwin and Abhay from all the doctors here, and myself for being around for the short demo. Thank you very much, and bye-bye, good night, and 73s. I'll just pull in the big switch and come in later at 10 o'clock. Bye-bye. Yeah. So I know I'm running out of time. So anyhow, so this was just a very small, brief demo. We got to talk to 4 people. One was in Manipal, one was in Kottara, the other one was behind you somewhere here in Attawar, and the other person in Hatton. Now this is a very small thing. We do this regularly, wherein I'll be in Mangalore, a friend will be in London, another fellow in Cape Town, another fellow in Helsinki, another guy in Singapore. So we talk like this, a huge network of people. So this is ham radio, and that is why the importance of ham radio is, since we know the technology, we can set up communication stations in case of emergencies very, very quickly. I think with that, I'll wrap it up for now. You have any questions, maybe 2 minutes, I can answer, and we are always available. My friend Dr. Ranjan is there. Vishnu Murthy is also there. Yeah. Okay, that's important. We'll give you, you can contact Ranjan, your own doctor. So we have 2 hams here. Your own president, Dr. Venugopal, is a ham, and Dr. Ranjan, both are hams. So we have many doctors. In fact, I don't know whether you knew this psychiatrist who's no more. His name was Dr. Osman Pasha. So Osman Pasha was the president of our club for a very long time. Very nice gentleman. So he was a ham. His call sign was VU2 Mike Oscar Papa, MOP. So we used to call him Mob. So very nice gentleman. So he was in our club. There are many doctors, all sorts of people, students, doctors, so many people. So Dr. Ranjan will help you. So the system is very simple. You have to register in our website today. Give a small exam online. You pass it, there will be some small verification and you will get your license. But this whole process, since it's government, it will take about 3 to 6 months for the entire process, start to end to finish. Okay, any more questions? Small questions if you have, I can take 1 or 2. Technical or otherwise. Of course, the subject is very vast and you can always contact me, Ranjan, Vishnumurthy, so many people. Yes, doctor.
Yeah, if there are any doubts, you can please post it to one of us, Dr. Ranjan or myself. We will clarify our doubts. It is very simple, as Rohith said, the examination is not tough. It doesn't involve a lot of electronics and all. It's a 1 week time you can.
It's a multiple choice question exams wherein you tick. It was different when I answered or when he answered, but now it's very easy. So you just tick some things. A little bit of electronics you have to study, and then rules and regulation. Of course, there's lots of rules and regulations. This license is not given to all and sundry at all, because it can be misused, badly misused. The power is huge, so our contacts, and many times during some anti-national activities and all, people used to contact us to find out what's going on, if you are eavesdropping or if you get any information. So things used to happen like this. Yeah.
Thank you, sir.
Okay, thank you very much. Sorry for pulling it a little long. I just could not pack so much. Thank you very much.
I would now like to request Dr. Venugopal and Dr. Achuth to present a token of love from IMA Mangalore to Mr. Rohith S. Rao. Now request Dr. M. Vijayakumar, Vice Chancellor, Yanapur Medical College, to enlighten us on the topic of Introduction to Comprehensive Cancer Care.
Good evening, everybody. At the outset, I thank the IMA for giving us this opportunity to do what we are planning to do today. And secondly, respected President of the IMA, the fellow members of IMA, my dear friends. Today I have been asked to talk on Introduction to Comprehensive Cancer Care. The first and foremost question obviously will come to us is, what is comprehensive cancer care? If you are a surgeon, you are going to think that surgery starting from small to big, open to robo, is comprehensive. If somebody is a physician, he is going to think about starting from pill to bone marrow transplant and so on. But when you are talking about cancer care comprehensively, we are only looking at the patient treatment, and that is not just comprehensive care. Comprehensive care includes, of course, patient care, which is the most important for us, and more importantly, the cancer care, we'll have to convey so many other things. It includes teaching and training and research as well. The comprehensive cancer care, when you are talking about it, when you are talking about patient care, it starts from the primary prevention, then secondary prevention, tertiary prevention. The primary prevention, when we are talking about health promotion activities. It could be in the form of cancer awareness program, trying to talk to them, preventing some people to take up certain things like lifestyle factors like smoking, etc. And the secondary prevention is related to the screening and picking up early cancers. The third one is actually the management of the proven cases. The primary prevention, again, there are two activities we normally talk about. One is the outreach activities, another is the extension activities. The outreach activities are meant to talk to people, health promotion activities, but no intervention. Once the intervention goes in, it becomes an extension activity. And most of us today are doing this, I'm aware, in the form of institute social responsibility. Obviously, it goes on. Just look at what we have done in our center. Thanks to the Rotary Club of Mangalore and the Rotary International, since we have started working on cancer awareness outreach program from last 7 years. So they identified us and asked us what could be done for the rural population. So the way we have designed and given, they have given a longest chassis possible, a vehicle which has got everything inside where we take to the rural people. This has got a mammography machine as you are seeing there. It has got a simple colposcopy. We can do oral examination, cervical examination, breast examination, and other counseling, etc. can be done in the same place. And that is what we are talking about. One of the ways of reaching the rural to do both health promotion activities and the mobile cancer detection activities. Seeing us doing that, in fact, I should be happy to convey this, that the government of Karnataka has come forward to fund us to do these programs in the tribal population, and we are doing it in the 5 districts, including Dakshin Kannada, Udupi, etc. So we were doing it along with the Mangalore, with the NSS program, and the Department of Sports and Youth, Karnataka, has given us this project to do this, and we have already completed around 2,000 people screening and early detection. On 17th onwards, for 1 month, we are planning to do it in Udupi district. Coming to the comprehensive cancer management, once we detect them, when they come to us, what we do is to prove the diagnosis and then stay the disease and then treatment. To do that, we have so many other investigations go on. We'll just see. This I have to dump down because somebody has already introduced. This is how the Tata Trust supported our Zuleika Institute of Oncology looks. This is the OPD, and that's the consultation room. These are minor OT and daycare ward. And to prove that, in the beginning we used to have only one, that is histopathology. And then we went on to have the cytology, and cytology has become a very big important tool as far as screening is concerned, particularly the cervix. And the FNAC came, that is a fine needle aspiration cytology, where we started using it as a tool even for diagnosis of the early disease as well as for the recurrent disease. Then came a change, that is the immunohistochemistry, which is now extensively used to categorize and subcategorize, which is going to help us not only to diagnose, but in fact dictate the treatment. I don't know how many of you know, for example, in breast cancer, the HER2 new is positive, then we use another one treatment. And in lymphoma, if the CD20 is positive, we are going to use another drug. So all these treatment protocols are changed and changing, and specifically because of the IHC. The two more armamentarium is, one is the cytogenetics and the next generation sequencing, which is coming up. The last two we don't have. Hopefully we'll have it in a year time. Coming to the staging part of it, the imaging. When we talk about, I started my career in 1980, we had only one, that is the conventional radiology, simple X-ray. In fact, there are no takers for MD radiology at that time. And you know what happened today. MD radiology starts the first and probably the most wanted specialty, where they can get away only talking, and always in the net down you can write the disclaimer. So the next came the ultrasound, where we extensively use the ultrasound, particularly for the cyst and solid, and also the liver, etc. we came in. But it is subjective, and the person behind gives the report, and that is what we have to depend on. Then comes the morphological one, that is the CT scan, you all know. For example, starting from a 2-slice CT, now we have gone in for 256-slice CT. For example, our institute has got 128-slice CT scan. So the CT scan in a high resolution came in, and that changed the whole scenario. For example, 1984 it came to Kidwai, we were the first to get it in Karnataka, the whole body CT scan, because till that time, Nimans had only a head scanner. You people would not have seen the head scanner. Today everybody has what is called as whole body CT scan, and that is what the norm today. Then came the MRI, the magnetic resonance imaging. The main important point here is it doesn't have radiation, as against the CT scan and X-rays, where they are exposed to the radiation, whereas MRI doesn't. Then came the game changer, I would say, the isotopes studies, that is the nuclear medicine, the PET and the SPECT. They are going to talk in detail, so I'm not going to further on that, but we have both the SPECT as well as the PET-CT. PET-CT is one which you can, positron emission tomography, where you can put the dye and see it is a functional imaging. That is why I'm talking one line extra. All others were till now is anatomical imaging, whereas the PET-CT is a functional imaging. I'm not taking more time because my colleague Dr. Senthilnathan will expand on that. Coming to the treatment part of it. The treatment part of it, if you take the three main modalities pillars, now the fourth one is coming in. That is the surgery, radiotherapy and chemotherapy. Whereas surgery is moving from the conventional big opening surgeries, and then we are going to the minimal invasive. Minimal invasive again is divided into conventional like laparoscopy and thoracoscopy or VATS, and now we are moving to robo. And in fact, I am happy to say that we are having robo for the past 7 years in Nanapa University, and that is one of the high-end models which we got, and we do around 120 cases, putting both urology and oncology together per annum. And this is my team of both urology and oncology there. And what you are seeing is the extreme end. Extreme end. This is the patient cot, this is the vision cot, and this is where the console where we sit and operate. It's like a remote, you sit in one corner and that is going on. And that is where the whole thing is. But the only thing, the difference between others, it came to corporates first, medical colleges very late. In fact, All India Institute of Medical Sciences, New Delhi was the first to take in medical college area. But in our university, 95% of the patients who are going through robotic surgery are below poverty line, and we are treating them cashless through Ayushman Bharat Arogya scheme only. That's the only difference, because that is the reason we are talking about comprehensive care in a medical college setting. In fact, I will take one extra minute to tell why I am here in Mangalore. I don't belong to Mangalore, of course. The reason was very simple. When I was the director of Kidwai, I wrote to Government of Karnataka, through Government of Karnataka to Government of India, and a proposal and a project proposal to set up cancer wings in all government medical colleges. To my own surprise, both the state government and central government accepted it, and they promised 75% from central government and 25% from state government. So I was thrilled as I wrote it in 2013. So I went between people, and it was moving. So I thought I am doing something great. Then came the election, and I don't know where my proposal went. So the whole thing changed. the government changed and my proposal went to I don't know where. So with the huff I came here, at least in one medical college, I thought I will do something and prove to the government that it is doable. This part is again radiotherapy, the true beam, which my colleague Dr. Achuth Nayak will talk in detail. Coming to the most important point, which I would say that every one of us have to think about this, when the new technology comes, when a comprehensive nature goes up, the cost of treatment goes up. It is inevitable because today the Da Vinci comes with around 20 crores of rupees, that is robo. And my true beam what I have put, thanks to Tata Trust who supported us, I didn't put, they put it, only we asked. So it is around 20 crores. So everything is in crores and asking them to do it in free is very difficult. But at the same time we have to do it. 85% of the masses in India are dependent on the public services, not in private service. And so how to make the cost bearable is the point which I have been working on, and there are many things which we have to do it. As I said, in Enapaya, everything and you come with a card, BPL card is done free because we get some money from government, Ayushman Bharat, Arogya Karnataka. But the money what they give is too small for many of the private sectors, it's true. Because if they are dependent on the hospital turnover and then to treat them, it is very difficult. And that's why I wrote to Government of India that medical colleges are the best placed to do this because the money comes from the tuition fees and the patient care can be secondary as far as income is concerned. So that is where we are able to do this. And the question comes is whether it is government, institution and individual. Ayushman Bharat, Arogya, I have been in government for 31 years to play for the government, and I was the person who was the chairperson of the task force of Government of Karnataka and I was sent to UK for studying the NHS guidelines and came back and started rolling it out when it was called as Vajpayee Arogya Shri scheme. Now it is amalgamated with Ayushman and it is called as Ayushman Bharat Arogya Karnataka, ABARC. Why I said that is, I'm neither a government servant nor a party person, but the point here is, it all started with actually Andhra Pradesh who gave the money, and it is more of an assurance. Some basic things have been taken care of. Now up to 5 lakhs per person per family per year. So that's a good amount which we should be able to use it for treating cancer. Otherwise I used to go in the past with a begging bowl to take the money because it was very difficult to support my poor patients back in Kidwai. Then comes the institution. Then the institution has to bear something because we are, after all, getting the patients for the sake of NMC, etc. Third one is individual. I would really bat everybody sitting here, please insure yourself. Do not think that the cancer will not hit you. I'm not cursing you, but anybody and everybody sitting in this audience can get it. So don't think you are an exception. Next comes the cost reduction. The cost reduction is one more thing. Costing is one, cost reduction is the other one. The cost reduction is about, for example, chemotherapy. It's very costly. If you know, the new drugs, the more the costly. Newer molecules, very costly. Sometimes the recent ones which are coming in as immunotherapy and biological modifiers are almost 2 lakhs per month, and he has to take it for 2 years to 5 years. I don't think I will afford that. So but the group purchase is one which has helped us to reduce the cost. This I am telling for the sake of everybody. If you are interested, you can become a part of it. That's called as National Cancer Grid, wherein I am the task force person in charge of we are doing it for 148 institutions in the country. We are talking about with the companies bringing down the cost because of the group purchase. For example, in the first round, we could get down from MRP, the average cost price which we bought was 44%. That is, an 100 rupee drug which is MRP, we got it for 44 rupees without any change in the substitutes or this. That is the way we can go about in group purchase. Anybody can use it as long as you are a part of the NCG. The sharing the resources is another one which I find sometimes amusing. Everybody wants to compete with each other and complain instead of complementing each other. but that is individual way of looking at it. Then comes the rehabilitation, the physical and psychological, social, spiritual, etc. In which the physical part is one more thing which many of the hospitals don't do. They think that after the treatment is over, they'll say thank you. Whereas we have taken up back in Appaya, where, for example, not only we are talking about occupational therapy and physiotherapy, I am talking about physically. For example, a post-mastectomy patient rehabilitation, not only the arm edema is important, but the pain, the patient will get what is called as post-mastectomy pain syndrome. After a year or two, the crowding of the ribs, and so they will develop pain. Any amount of painkillers will not help. You have to give a weighted prosthesis, which is equivalent to almost the contralateral side of the lady, which costs around, the imported ones are costing around 10,000 rupees, silicon one. We have started preparing our own in our center, and we are able to sell it around for 3,000 rupees. Now I do not even ask them whether they want it. Most of our women will say no, without realizing they think it is a cosmetic part. We don't ask them which antibiotic use, which chemotherapy to give, we only inform them. Same way, we are planning to give them what is required for a long term, and of course the cosmesis body image is one side, but more importantly, it is for the long term benefit of the pain, which we have started using it. Next comes the palliative care. When I came in itself only, I started the department with the community oncology on one side and palliative care on the other side. People were asking me, why did you start with palliative care? They don't know 40 to 50% of the patients on presentation will go to palliative care. That is our country. In 1970, the WHO said the aim of treatment is cure sometimes, palliation often, and comfort always. This comfort always is what we are talking about. We in our country, I do not know how many of you know the statistics, the ICMR white paper says, as on 2020, only 12% of the people who are coming to the hospital on cancer setting come in an early stage. 12%. That means 88% of them are coming in either locally advanced or metastatic disease. At some point or other, palliative care becomes important and symptom control takes care. And the last most important thing is the care of the terminally ill care. In fact, one Tapasya Foundation is there in Mangalore. I am associated with them. They have started it in somewhere near Mudipu. They are just building it. I'll be happy if you can help them to establish and run it. It's a terminal care and palliative care. When nothing more can be done, such patients are treated. Next totally it is in the different level is the research. Everybody talks that the research is not in our background and we don't do that, etc., but nobody applies. But some research has come 25 years ago, I'll say, is on the clinical side. Clinical trials came in 1990, and that is the only thing probably most of the hospitals are involved. Whereas back in our center, we have got the basic as well as translational research. And this is one more thing which we started. It's called as Appaya Technology Incubator about 3 years back, wherein you come with an idea, we will get you not only the funding, we help you to nurture your idea to make it industry ready. Many of these ideas stop with probably papers and publication, not beyond that. But we will make the dream come true by making it industry ready, and we are totally supported by Government of India with the biotechnology, that is DBT, DST, BIRAC, and then MSME. So all these government agencies are supporting us, and we are there to incubate you, support you, and if you are a startup, reach us, we'll help you for anything related to health. Only 4 centers in the country are recognized. For health related, only 2. One is ours, the other is C-Camp in Bangalore. The non-health related is IIT Bombay and IIT Madras. So only 4 centers, and you are all in Mangalore. Kindly use it. It is a separate entity. We have kept it, not directly associated with the running, functioning part of it. It is not directly related to university. It's a Section 8 company, no loss, no profit, so that anybody outsider can come and use it and go. Next, last but not least, to be the quality. As the number increases, as we grow, more and more problems will happen. Is as the quantity goes up, the quality suffers. The most important thing from the beginning only, you have to develop the systems where quality is sustenance and then enrichment of this quality, and lastly the enhancement. How do we do that? there are quality solutions available. And for example, we go through the peer review and other independent reviews. Many of you would have gone through that, NABH for example, and then NABL for the labs, and of course the NAC for the university, we are A+, and NIRF ranking comes. All these are quality issues. As far as the hospital is concerned, it is NABL and NABH. And how do we do that is through the IQSC, that is Internal Quality Assessment Council. We keep it. It's every year we go through that, and then the peer review. Peer review means we request people from outside to come and see, like an external auditing, and see that the quality is maintained, and then only we can enrich and enhance. And I thought just it's an introduction to you about what is comprehensive care. It is not about just treating, it is much more than that. Thank you very much for your attention.
Thank you, sir. We will be taking the questions at the end. Next, I would like to request Dr. Achuth Nayak, MD Radiation Oncology, Assistant Professor in Yanapur Medical College, to throw some light on the topic of radiation therapy in oncology.
Respected President IMA, other eminent IMA members. So I'll be talking about radiotherapy in oncology. So by my presentation, I would just like to give a brief idea of what we as radiation oncologists do, other than sit in isolated bunker somewhere below. So radiation therapy essentially involves use of megavoltage X-rays, or we also deal with electromagnetic spectrum. Like the previous speaker had told about radio waves, we also deal with electromagnetic spectrum, but on the other side of the electromagnetic spectrum. So it is with the higher frequency and high energy X-rays which are used to kill the tumor cells. So damage to the tumor cells usually happens by damaging the DNA. So what are the indications for radiotherapy? If you go into the cancer side, from top you see oral cavity cancers, oropharyngeal cancers, laryngeal, hypopharyngeal, brain tumors, lung cancers, esophageal cancers. So literally all solid cancers in the body from head to toe, somewhere or the other radiotherapy is indicated. So it is easier to say in which cancers it is not indicated. So only in bone tumors, off the top of my head, it is not indicated. For non-oncological cases, recurrent pituitary adenomas, schwannomas, glomus tumors, thymomas, keloids. So all these things, radiations are used. So almost 2/3 of cancer patients require radiation in some form or the other, either as a radical treatment or as a palliation. So what is the treatment process like? So once the patient we see in the OPD decide that, okay, radiation is to be planned, what next? So the first part of it is what we call simulation. Simulation is we use a diagnostic CT scanner and we position the patient in a particular way. So this I have shown in a pelvic tumor patient. I think it's a carcinoma cervix patient, which we have positioned straight. So you can see the lasers. We align the patient in a straight position, mark on the patient body, and then take a CT scan. So this is the same thing that we do for a head and neck cancer patient. You can see that there is a mask which is made. So this is made of a thermoplastic material. So you dip it in hot water, and then cool it down, and then put it on the patient, and it conforms to the shape of the head. So after the CT scan is acquired, how do we see the target? So sometimes some tumors are not visible readily on the CT scan. So we use PET scan to overlay the image of the PET scan onto the CT scan that we have acquired, so that we can see this tumor better. Sometimes PET also we can't see properly, especially in cervical cancer patients. So we use MRI, which has been done earlier, and then we fuse the MRI to our CT scan image, and we draw basically on the CT scan what is to be treated. So that is what is called as target mapping or contouring. So generally this is how the target volume looks like after we have drawn it. So this is a case of carcinoma cervix. So we have included the pelvic lymph nodal basin, the uterus, the parametrium, ovaries. So till now we have finished with planning the patient. So what exactly do we do while delivering the treatment? So this is external beam radiation. So the types of external beam radiation are three-dimensional conformal radiation therapy, IMRT, VMAT, IGRT. So these are all very fancy terms to hear, but it's a little simple to understand. So the recent advances that have happened in radiation are in IMRT, VMAT and IGRT. So I'll just be showing you a video of the same. So this is a patient who's having a brain metastasis and whole brain radiation treatment we are giving. So you can see the white areas there. So this is basically on the machine. So this is something which is called as multi-leaf collimators. So this shape the radiation beam according to whatever you have drawn. So here you can see that the patient is getting treated. The whole brain radiation is getting treated on one side, and then the gantry moves to the other side, the machine moves to the other side, and the other part is get treated. So this is what is called as 3D conformal radiation therapy. So a higher version of treatment would be something called as volumetric modulated arc therapy. So what happens is this gantry moves all around the patient, and while this multi-leaf collimators that I told you about, these keep on moving, changing the intensity of the radiation beam so that the radiation dose is confined to wherever we need to treat, and it unnecessarily does not affect the normal tissues around. So as you can see, these are continuously moving, and the gantry also is continuously rotating around the patient while the radiation beam is on. So this kind of treatment usually takes around 5 to 10 minutes. The patient has to lie down for 5 to 10 minutes and the treatment is over. So each session, it is like this. So each session would be 5-10 minutes, which the whole treatment would be lasting for somewhere between 1 to 1.5 months. So what exactly is the difference? As I told you, 3D conformal radiation, the whole area basically gets fired with radiation. If you can see the green area on the left hand side, the whole area gets fired with radiation. Whereas on the right hand side, this is the advanced radiation treatment, which actually spares the bladder and the rectum behind, so that the acute side effects during the treatment can be avoided. Another advantage would be you want to give a different dose to different sites of cancer at the same time. So that is possible with VMAT. Unlike with 3D CRT, you can give only one particular dose to the whole area. Can't give a differential dose to different areas. So after the planning, everything is done. While delivering, before delivering, on the machine, there is a facility to take CT scan also. So on the machine, the CT scan is done. The position of the patient is verified. We check that wherever we have planned, the same area is getting treated or not. Confirm it and then give the treatment. So as you can see in this area, the red area is where we have actually drawn on the CT scan on the left hand side, and the right hand side is the CT scan which we have done on the machine. So you can see that the uterus is actually going out of the treatment area. So in such situations, we take the patient back out, make sure that the target is again inside the whatever we have drawn, and then treat the patient. So this makes it doubly sure that wherever we have drawn, there the treatment is going. So this is something which is called as image guided radiation therapy. So you use the image which is available on the radiation machine to guide the radiation treatment. So what are the other advances which have been there in radiation therapy? So apart from all this, so generally what happens in radiation is we give somewhere about 2 gray in one sitting, and which goes on, as I told you, for 1 to 1.5 months. So something called a stereotactic radiation has come into the picture. So it is a type of external beam radiation wherein a clearly defined target is treated with a very high precision and accuracy to a very high dose. for example, somewhere between 12 to 20 gray in a single sitting with a curative intent. So what happens here is that similar to many beams converging together on a single spot. So if you can see the blue areas which are converging on a single spot. So like that the radiation gets delivered with high precision and accuracy. So these are few pictures I took of the left hand side is trigeminal neuralgia. You can see on the red, the left hand side, the red region which is drawn. So the target is that small in trigeminal neuralgia, and you can see how close it is to the brainstem, less than 5 mm. So that is how accurate you have to be to avoid the brainstem, and because mind you, you're treating that to a very high dose, 20-24 gray. So that goes to the brainstem, that much dose goes to the brainstem, that will be catastrophic. So then the middle you can see AVM, arteriovenous malformation getting treated, and on the right hand side brain metastasis. So the same thing that you do in the brain, when you use it outside or extracranially, that is called as stereotactic body radiation therapy. So that usually we use in other areas of metastasis. So in the left hand side you can see for the vertebral metastasis. In the middle for the carcinoma lung we use it, and for prostate also, that SBRT has been come up now. So what is the other advance that we have now on our machine? So generally if you are treating a lung cancer, you can see that the patient is breathing during the treatment. So during each breath that the patient takes, the tumor also moves. So during this movement there is a high chance that the tumor will get missed and it will result in inadequate cancer control. So what happens is, so this tumor is what is depicted in red inside the lung, and which keeps on moving with respiration. So there is a specialized diagnostic CT available at our institute, which takes into account the breathing movements which happen during the CT planning, and all the breathing movements that how the tumor moves is taken into account in the CT scan, and then we plan the patient. So what happens is, during each phase of respiration, suppose in inspiration the tumor motion is less, so we can treat the patient So this is an infrared camera which is part of the system, and this is an infrared marker which is placed on the patient's body. So the infrared camera detects this motion of the infrared marker, and then the respiratory movements are detected by the computer. So this green way is the radiation beam which is getting and coming and treating the patient. So only in certain phases of respiration the beam will be turned on automatically, so that wherever the movement is minimal, then the treatment happens. This is especially useful in lung cancers. Another use of motion management would be in left-sided breast cancers. So this is something that we call as a deep inspiratory breath hold. We ask the patient to take a deep breath and then take the CT scan and also deliver the treatment in a breath hold position. So what happens is the breast moves out, and there is a space which is there between the heart and the breast, like you can see on the right hand side, and the radiation is avoided and the heart does not receive much of radiation, so that the long-term effects of cardiac toxicities, which everyone is talking about, gets minimized after breast radiation therapy. So what is the second type of, so till now I have been talking about external beam radiation therapy, that is the radiation comes from the outside source and goes into the patient's body. So there is another type of radiation which is called as brachytherapy, wherein radioactive sources are implanted inside the tumor and high doses of radiation are delivered. So generally there are two types of internal radiation therapy or brachytherapy. One is intracavitary, wherein the sources are implanted inside a cavity, namely either cervix or uterus. Interstitial implants are wherein sources are placed directly into the tissue and then inside it is treated. So this is example on the left hand side of an intracavitary applicator which we generally use for carcinoma cervix. So this straight part goes into the uterine canal, and the side things that you see go into the vagina, so that this whole area, uterus and vagina and the parametrium, are treated to a high dose. So this is how it looks like. This is the dose which goes to the uterus and the cervix. So generally we give somewhere about 7 to 8 gray in a single sitting, and you can see that there is very little dose which goes outside the target volume, that is the uterus. So this is the same thing which is for interstitial, that is what I told, needles are implanted inside the tumor and penetrated inside the tumor. So this is a case of CA cervix, wherein again we have put needles inside, and this yellow area is where the radiation dose is going. So this is the radiation machine wherein the radioisotope is housed, and it goes outside into those tubes into the patient's body through the needle, and then it comes out. So even in brachytherapy, right now brachytherapy generally what we do was take a CT scan and then plan on the CT scan. But cervical cancer usually is well visualized in MRI. So MRI guided, image guided brachytherapy is another type of in brachytherapy which is coming up, wherein you can easily identify the tumor which is left, and then you can treat whatever tumor is left with the radiation instead of the whole thing. So these are some patients that we treated. So this is a case of carcinoma cervix post pre-RT on the left hand side. Right hand side is where we treated post radiation around 1.5 to 2 months. The MRI scan was taken. You can see there is a complete response in the tumor. This is again the same patient. She had a big lymph node also, which has also completely responded to treatment. This is another case of base of tongue, oropharyngeal cancer with a big lymph node, which you can see, which has completely responded to radiation. Another case of laryngeal cancer, which has responded to radiation. So this was an interesting case which came to us, a bladder cancer case, squamous cell carcinoma, which had a tumor which was then completely going into the anterior abdominal wall. So if we operated up front, it would require a very morbid procedure. So wherein we had given her radiation, and then on the right hand side you can see the kind of response which has happened. So the abdominal wall part of the tumor has almost completely responded. So she later underwent a radical cystectomy, and the histopathological specimen actually showed a complete response in this. So this is another case of plasmacytoma, which is an earlier stage of multiple myeloma, which presented to us. So this is post-RT, almost it is a complete response. So I am proud to say that since 8 months since the inception of our institute, we have treated 400 plus patients and helped them. So hoping that in the future we can help many, many more patients. Thank you.
Thank you, sir. Next, we have Dr. Senthilnathan, MD Nuclear Medicine, Associate Professor, Yenapoy Medical College, to talk about nuclear medicine in oncology.
Good evening, everyone. First of all, I would like to express my sincere thanks to IMA Mangalore branch for giving me this opportunity. Nuclear medicine is a branch which deals with the application of radioisotopes in the diagnosis and treatment of various diseases. These radioisotopes are basically unsealed radioactive materials, in sharp contrast to what we see in radiology, where everything is in a sealed source. Usually these isotopes are in the form of a liquid. In nuclear medicine, we basically deal with these three types of rays: alpha rays, beta rays and gamma rays, which we already know what they are. Just to refresh, alpha rays have got the most ionizing potential and they are the least penetrating and hence they are used for therapy. Gamma rays on the other hand, they are the least ionizing and the most penetrating and hence they can be used for imaging diagnosis. Beta rays in between these two, still they are used for therapy. In oncology, nuclear medicine has got both diagnostic as well as therapeutic applications. If we look at the diagnostic applications in oncology, the first and foremost thing which merits attention here is this PET-CT. This is an abbreviated term for positron emission tomography combined with the conventional computed tomography. This is an imaging modality and this has basically revolutionized the practice of oncology and it is almost synonymous with the diagnostic cancer care in nuclear medicine. So what is positron emission tomography? Tomography means ultimately we are going to have sections of the body, so we will be having ultimately a sagittal, axial or coronal sections. This is an imaging modality where positron emitters are injected into the body and the imaging is done. A positron is nothing but an antiparticle of electron and on emission, positron on its emission eventually leads to the production of two gamma rays in opposite directions, exactly 180 degrees to each other. So when we inject, these gamma rays come out of the body, hit the camera and produce an image. In sharp contrast to radiology, this provides either metabolic or functional information. Radiology usually deals with the structural changes happening inside the body. This is how a PET-CT scanner looks like. This is an integrated machine containing both the PET component as well as the CT component. So how a positron emission tomography image would look like? This is one of the axial slices. This is how a positron emission tomography image would look like. But with this image alone, it is hard to tell what it is exactly. There are some areas of heterogeneity, some areas showing increased uptake, some areas showing low uptake. So it is with this image alone, it is hard to tell what is happening inside the body. For this, we need to have the help of a computer tomography because on the left side we can see an axial image of the CT taken at the level of L1 vertebra. So since it provides the anatomical information and positron emission tomography provides the metabolic information, we can fuse these two images and get an image like this. Now it is easy to tell. So I don't have a point, sorry. This is taken at the level of L1 vertebra. There in the right transverse process of the L1 vertebra, we can see some amount of increased activity, which is pathological. This is based on experience. I'm telling this is pathological. And kidney is part of the injected. This was actually done with radioactive glucose analog. So that gets part of it. It gets excreted through the kidneys. That's why we see some amount of activity in the kidneys. Stomach activity is physiological because of its motility, basically. And rest of the things are almost physiological activity. So the need for CT is only for localization of the lesion. We can easily tell where exactly the pathology lies. And since the CT scan provides attenuation values, we can actually quantify the degree of uptake of the injected radiopharmaceutical or the radioisotope. And third thing, since it is a fully diagnostic CT scan, it helps in characterization of the lesion. So where is the need for positron emission tomography? And that too in evaluation of cancer patients, right, starting from the history, physical examination, lab tests, x-rays, scopies, ultrasounds, CTs and MRIs. So where exactly is the need for a positron emission tomography? For this, I need to explain this. The most commonly used radioisotope or the radiopharmaceutical in positron emission tomography is this F18-deoxyglucose, abbreviated FDG. This F18 is a positron emitter, and this whole molecule is a radioactive glucose analog, behaves like glucose to a certain extent. So it is basically a marker for the tissue uptake of glucose. The rationale is this: most of the tumor cells exhibit increased glucose consumption and hence metabolism. So in tumor cells, what happens is, compared with the normal cell, here we can see in a tumor cell compared with the normal cell, there is overexpression of this glucose transporters across the cell membrane, and there is upregulation of the hexokinase enzyme. All these contribute to the increased uptake of either glucose or the injected FDG into the cell. The basic difference between glucose and FDG here is that glucose gets metabolized further after its phosphorylation, whereas FDG does not get metabolized after its phosphorylation, and it gets trapped inside the cell, which will be seen as hotspots in the scan. So that's how a normal cell versus a cancer cell look like. We can see there is a umpteen spots which basically indicate the uptake of glucose here, as well as FDG when we inject, that also will be taken up in a higher manner in a tumorous cell. The advantage of PET is it provides metabolic information or functional information, and these metabolic changes precede anatomical changes. So we need not wait for an anatomical change to happen. It is enough if there is some amount of metabolic information which will reflect the presence or absence of cancer. This is how a normal whole body FDG PET scan would look like. We see great amount of activity in the region of brain because the major substrate is glucose for brain. So it takes up glucose or FDG in a much higher manner, and that's why we see this much of activity in the brain. And the palatal tonsil, lingual tonsil, they're all due to physiological uptake of FDG in the lymphatics. Part of the injected FDG gets excreted through the kidneys. So that's why we see activity in both the kidneys and in the urinary bladder. And then there is some amount of subtle uptake in liver, spleen, stomach. This is all physiological activity only. Myocardial uptake may or may not be there depending upon the level of fasting. We usually ask the patients to fast before doing an FDG scan. Do we need to tell whether this is a normal or abnormal scan? This is obviously an abnormal scan. It was referred as a case of non-Hodgkin's lymphoma. Basically, it shows clearly the presence of supra and infradiaphragmatic lymphadenopathy in this patient. All these dark spots are all uptake by the tuberous cells, in this case the lymph nodes. And there is an uptake in the region of liver as well as in the spleen. Here we can see this is an axial image of the same patient. The focal hotspots we are clearly seen in the fusion image there, whereas the CT is absolutely normal in the spleen. So that's how it makes a difference actually. Coming to the clinical applications of PET-CT, some of the clinical applications include, the first and foremost would be the staging of known malignancies. We can easily stage because you are going to do a whole body evaluation. Response assessment, tumor versus post-treatment fibrosis. If there is a residual tumor, it's going to show some uptake, whereas if there is fibrosis, uptake is not going to be there. And in patients with unknown primary, it helps. And apart from this, as Dr. Achuth told, can be used for radiotherapy planning, then it can be used to differentiate a benign disease from a malignant disease and so on. This was a patient who, with the pre-op diagnosis of glioma, underwent right parietal craniotomy and tumor excision. This is the post-op scan actually. Let me tell the history before that. The HP of that lesion came out as suggestive of metastatic carcinoma. IHC was in favor of metastatic undifferentiated carcinoma, with the possible primaries being in the upper aerodigestive tract or in the pancreaticobiliary region. The patient was referred subsequently for a whole body PET CT. And this is the post-op image. This activity which we see here, that yellow activity, that is the residual tumor after excision. And when we did a whole body PET CT, of course the CT also picked up. There is we can see that irregular soft tissue density lesion in the right lung. The CT also picked up, as the PET image also. It clearly shows the metabolic information. So this patient was referred recently actually. So I don't know the histopathology of this image, but this must have been the culprit lesion in this case. On mediastinal note, the same patient. Here we can see the yellow spot showing the mediastinal adenopathy. Getting into the specifics of F18 FDG PET CT, I will just quote a few examples. For lymphoma, FDG PET CT has become the primary imaging modality for staging and assessing treatment response in patients with FDG-avid lymphomas. The vast majority of FDG-avid lymphomas are FDG-avid, including the most common ones, Hodgkin's, diffuse large B-cell lymphoma. Non-small cell lung cancer, FDG PET CT may prevent from 1/3 to 1/2 of surgical resections by the demonstration of otherwise unknown extent of malignancy. And this has got a high negative predictive value for mediastinal and hilar nodes, as well as for distant metastasis. CA esophagus, FDG PET CT has a demonstrated value for the detection of local subcentimetric nodal metastasis, which may be overlooked on anatomical imaging. CA cervix and C endometrium, FDG PET CT has demonstrated the best sensitivity for identification of pelvic and retroperitoneal nodal metastasis as well as distant metastasis. Nodal metastasis per se, FDG PET CT has the ability to detect nodal metastasis in subcentimetric nodes, which may be overlooked on CT or MR. Sort of repetition only this one. This has been demonstrated throughout the body. The good examples being head and neck malignancies, lung malignancies, GIT malignancies, and genitourinary system malignancies. This is what we call the gamma camera. This is a slightly different modality from PET CT in the sense that the applications are different, the radio setups which are used for this are different, and the infrastructure is different. That is the head of the gamma camera, that's the gantry and the couch. Cross-sectional imaging with this modality is called SPECT. Gamma rays are otherwise called photons actually. In PET what happens is, as I told you earlier, 2 gamma rays are emitted and the gamma rays are detected by means of the camera. Here only a single gamma ray is emitted with every radioactive decay. So that is the basic difference. Here we use radiopharmaceuticals, different ones. The most commonly used radioisotope is technetium-99m, and depending upon the organ system to be studied, we have different pharmaceuticals. Say for example for kidney function and its to look for the presence or absence of obstruction, we use DTPA. For bone scan, we use this MDP, methylene diphosphonate. This is a whole body bone scan done with technetium-99m MDP. This is how a normal whole body bone scan will look like. And this is a patient with multiple skeletal metastasis. A technetium-99m MDP bone scan revealing the presence of multiple irregular foci with increased uptake, depicting the presence of wide disseminated skeletal metastasis. But the difference between this modality and PET is that goes to any tissue which harbors malignancy, but here it is specific for the bones. And therapy, iodine-131 therapy, high-dose iodine-131 therapy for patients with a differentiated CA thyroid in a post-surgical scenario after a total or a near total thyroidectomy reduces both morbidity and mortality. bone pain palliation with phosphorus 32 or strontium 89, samarium 153, especially for patients with CA prostate and CA breast having disseminated multiple metastasis, pain which is not relieved by other modalities, we can think about this radionuclide therapy. Thank you.
Thank you, sir. Please note, feedback links will be provided. Please provide the feedback. Next, I would like to request Dr. Rajesh Krishna, Associate Professor, Hemato-Oncology, Yanapa Medical College, for the next talk on BMT in oncology.
Good evening, everyone. I know it's getting late. First of all, let me express my sincere thanks to my colleagues in IMA, particularly the IMA President Dr. Venugopal and Dr. Achuth and Dr. Nandagopal for organizing this meeting and allowing us to talk. And respected senior colleagues and my friends. So today's I'm going to talk about BMT, which is bone marrow transplantation, and I have added a prefix affordable, and my Vice Chancellor Professor Vijayakumar sir had spoken about our population and that we cannot spend a lot of money on most of these sophisticated treatment modalities. So our aim and endeavor has been to bring treatment modalities which are available in metros to a second tier city like Mangalore. So first of all, let me talk about the definition of stem cell transplant. So this is a procedure in which patient receives healthy stem cells. Now stem cells are the cells which form blood, basically your neutrophils, white cells, and platelets and red cells, to replace the stem cells that have been destroyed with treatment. So basically what you do is the deceased patient's stem cells are destroyed using chemotherapy or radiotherapy in this procedure, and the healthy stem cells which have been collected either from a donor or from the patient is infused back to the patient. So as I mentioned, the healthy stem cells may come from the blood or bone marrow of the patient or from related or unrelated donor. Now there is always a question, what is bone marrow transplant, what is stem cell transplant? So both are basically one and the same. Basically this arises because these days the stem cells are collected using apheresis rather than from the bone marrow puncture. So the types of stem cell transplant: autologous, which is using patient's own stem cells that were collected and saved prior to transplant. So what happens here is basically the stem cells are collected in a patient once they attain remission and given after high dose chemotherapy. The next is allogenic, that is from a donor. This can be unrelated or related, such as a sibling donor. Syngeneic is donated by a identical twin. Cord blood is using umbilical cord blood donated after a baby is born. I'll talk more about autologous transplant first, because that is what we have been performing over the last 3 years. Now this is to consolidate the response mainly in myeloma, lymphoma and neuroblastoma. So what we do is stem cell collection is done after the patient goes into remission, and thereafter a high dose chemotherapy is given and then transplant is done. Now briefly about indications for allogenic transplant. So as I mentioned earlier, allogenic is basically from the donor. This can be either related or unrelated, and the usual indications are high risk leukemia, relapsed lymphoma, high-risk myelodysplasia and high-risk myelofibrosis. Now it can also be done in benign disease like thalassemia, inherited metabolic and immunodeficiency syndromes. Let me go through a few illustrative cases. So this is our first transplant. This is a 55-year-old gentleman with anemia and renal impairment. He underwent a bone marrow biopsy, and that showed this picture whereby 50% plasma cells confirming a diagnosis of multiple myeloma. So myeloma is a incurable bone marrow cancer which affects bone marrow, blood and the kidneys. So however, despite it being incurable, we have a lot of treatment modalities, and most patients survive anywhere from 6 to 12 years. So the fit patients who can undergo stem cell transplant often survive for up to a decade or more, and unfit patients, their life expectancy is shorter. So this is from one of my clinics. So the demographics shows that the average age is 70 years. So this is a cancer of the older people. Now saying that age alone is not a bar for transplant, it is the fitness. However, over the age of 70, they become less and less fit. In Zulekha Yanapoya, we have transplanted one patient aged 71 years. Now this was because he was quite fit. He was a farmer. He used to walk 3 to 5 kilometers daily, did not have diabetes or hypertension, and his physical state was that he would endure this procedure. This is just once again plasma cells and renal biopsy showing cast nephropathy. Now, as I mentioned, if it's an incurable cancer, why do you do a stem cell transplant is the next question. So, the life history of myeloma, the natural history, shows that it is a disease whereby there is an active myeloma, and on treatment patient goes into remission, and then again it relapses, again it goes into remission. So what happens with our conventional combination chemotherapy is that we can take the patient to a remission, and this remission may last for maybe a year, 2 years or 3 years. Now the aim behind doing a stem cell transplant here is to deepen the remission. So this essentially means that we are trying to remove or kill as much myeloma cells as possible so that the duration of remission is doubled. So generally when I counsel the patients, I quote that, see, this disease is going to come back. However, at first remission, that is the best period in your life because you can lead a normal life. So a autologous stem cell transplant in this setting would mean that they have many more years to live normally. So that is why we would strongly recommend that all myeloma patients who are in remission and who are fit for transplant undergo this procedure, because the duration of remission would be much longer. In the United Kingdom, we were doing 2 transplants. Even at second remission, we were doing depending on the fitness of the patients. So technically, a myeloma patient could have 2 transplants, and the second one would be done only if the duration of response in the first one was long. So what do you look when a new myeloma patient comes? So what do you look at the patient to see whether he is a candidate for intensive treatment or non-intensive treatment depending on his physical fitness. If it is an intensive, if the patient is fit enough for intensive treatment, then you give combination treatment to take them to remission. And myeloma, we don't have to keep on doing bone marrows. These days we got markers We got serum protein electrophoresis to look for the M band and the serum free light chains. We monitor them till they go into remission. And then if they're fit enough, obviously go for a transplant. For patients who are not fit enough, of course, we have got other options available. This slide I'll just run through. Basically, it's a combination treatment. Most of myeloma treatment is as an outpatient. In the day ward, they often come once a week for injections, and mostly it is outpatient treatment. So, going back to autologous stem cell transplant in myeloma. So, first I counsel the patient with regard to the need for the transplant. Then of course we look at whether the patient is in remission or in a plateau, which means they are near remission or nearly 90%, which is called a very good partial response, more than 90% response, and they are quite stable. And then we look at their heart with echocardiogram, lung function tests, and sometimes do a EGFR if we are worried about the kidney, and basically ensure that they are fit for the procedure. Then we counsel that they have to stay in isolation for around 3 weeks. So the procedure consists of basically stem cell mobilization. We use GCSF to mobilize the stem cells. 4 days of GCSF is given, and often we give Plaraxifer, which is another agent to mobilize stem cells. These are subcutaneous drugs, and then we collect the stem cells using a apheresis machine. Now, many a times the patients think, this is an operation. So, and even if you look at the recent paper cuttings, they said Shastrakriya. So then we have to tell them, see, this is, a collection that is done using the apheresis machine, where they have to sit in front of the machine for 4 to 6 hours. Sometimes the collection may not be adequate. So this is also counseled before, that we need at least 2 million stem cells to proceed. Now, if it is not adequate, we may do a second collection. And once we ensure that we have got enough or adequate stem cells, then we proceed with the high dose melphalan chemotherapy. So, obviously the aim of the melphalan is to kill the remaining stem cells. However, it is a high dose alkylating agent, and obviously it is going to cause other side effects also. Now, in 24 hours, the melphalan is excreted from the body, and after it is excreted, the stem cells are returned. Now, this is a picture of an apheresis machine that is somewhat similar to dialysis machine. We do insert central line for the patient so that blood is collected through the central line to the machine and then returned. If the veins are very poor, sometimes they may need 2 central lines. Often we would proceed with the chemotherapy soon after collection. So this may mean that the central line that we have placed, one of them we keep because we need it again for the next couple of weeks. So what happens here is, see, we have given the 4 days of mobilizing drugs, then 1 day we collect, sometimes we may collect for the 2nd day, and after that we give the melphalan chemotherapy. 24 hours after that we give the stem cells. As the duration of chemotherapy is for only a single day, in myeloma we don't need to cryopreserve. We can store the stem cells safely for up to 48 to 72 hours in 4 degrees Celsius. So to reduce the cost, as our aim is to make it affordable, we are storing it fresh, and then we return. Now obviously we have wiped out all the young dividing cells. So this patient goes into profound cytopenia, which means after 2 or 3 days they become neutropenic. They also become thrombocytopenic, and also they become anemic. So we have to give them blood and platelets. Now obviously with the blood, as we know, red blood cells will last for for up to 60 days in the body. So we often end up requiring 2 or 3 units of red blood cells. So that is not so difficult. But platelets are a major problem because platelets last only for 24 to 48 hours in the body. So there is a huge need for these patients to receive platelets up to 1 week to 10 days. So we have a lot of need for platelets. Now the other important thing here is, see, these patients are, their immunity is quite low. So if you give donor platelets, the stem cells in the donor platelets or the T cells can cause transfusion related graft versus host disease. Hence, we have to irradiate the donated red blood cells and platelets. So they are irradiated and then given to the patient. Next is infections. So that is the major headache because we keep the patient in a HEPA filtered room where the aim is that even a fungal spore should not reach the patient. However, there is endogenous bacteria usually in the gut, and the chemotherapy causes kills the young dividing cells in the gut, and you have mucositis in the gut and mouth. So invariably they get a gram-negative infection. So they get a fever and we have to manage neutropenic sepsis, and often that is quite difficult because sometimes it can be profound continuous fevers. We send blood cultures and we have got protocols in place for antibiotics and management. Now I did mention that we have mucositis. Now that does cause diarrhea, and diarrhea can be profound and very difficult to contain, and often we don't know whether there is some infection, so you can't simply give loperamide and stop the diarrhea. So we have to manage fluid and electrolytes. Often that again give potassium, magnesium supplements. So it is quite stressful, but with a good team we can manage properly. Now that is about myeloma. Now the average engraftment, now when I say engraftment, that means the stem cells that we have given have started producing neutrophils and platelets. The average engraftment for us is around 10 to 11 days. Now what is the difference between myeloma and lymphoma transplant is, in lymphoma the chemotherapy is given over 6 days, unlike a single day in myeloma. So you can't store the stem cells for those 7-8 days in 4 degrees Celsius. So we have to cryopreserve the stem cells using an agent called DMSO. That's a specialized procedure which we do in our blood bank, and they are preserved in minus 80 degrees Celsius. After we give the 6 days of chemotherapy, we thaw the stem cells and then they are returned. Now again we have preserved them with the DMSO, so it has its own toxicity such as cardiac toxicity, so we have to be careful, we have to monitor the patient, so all those problems are there. And again, the degree of neutropenia is much more profound in lymphoma because of the longer duration of chemotherapy, and the sepsis is much bigger problem. So again, longer neutropenic sepsis management and profound mucositis and diarrhea which we have to manage till engraftment. But it is miraculous to see that once we see the engraftment, the patient recovers rapidly. Now talking about our affordable stem cell transplant, I'll briefly take you over our experience. We have done 12 affordable transplants at the so far. 7 of them have been for myeloma and 5 of them for relapsed lymphoma. The mean engraftment has been day 11 and our cost has been around 3.5 lakhs for myeloma and 4.5 lakhs for lymphoma. And I think this is less than half the cost of the corporates in metros. However, there is a caveat to that, like the small print you see everywhere. If they get multi-drug resistant infection, the cost goes up. And of course, if they did go to ICU, the cost would go up. Now, what has been our complication? Now, all of our patients have had fever and neutropenic sepsis, which we have managed with drugs like meropenem and teicoplanin. We have had one case of multi-drug resistant Klebsiella, where it was very difficult to manage. However, using a cocktail of antibiotics including ceftazidime, avibactam and aztreonam and polymyxin and everything, we managed to keep the patient alive till engraftment. And again, it was so interesting to see that the body's own neutrophils do a much better job than the antibiotics. Patient improved after that. Now the cost though did go up to around 8 lakhs. But again, from what I hear, if this patient was in a corporate hospital, the cost may have been 20 lakhs in a bigger city. We had one case of Candida tropicalis, and one patient contracted COVID-19 from his partner around the time of engraftment. She had snuffle, so that the relative sneaked in and gave COVID. Now that patient had to be shifted to ICU for CPAP. However, he had vaccinations previously, and we are very happy to say that he survived. And that is one of the very few cases that you see in literature where a patient peri-transplant has had COVID and survived. And almost all of our patients have had diarrhea and needed intensive electrolyte management. Talking about pediatric transplant, again with the pediatric cases, it's more challenging because adults, it's they understand what's going on. Children, sometimes it's more difficult, and the parents add to the anxiety, and then the drug doses are different. We did a transplant on this 14-year-old girl with the relapsed Hodgkin lymphoma in remission. She again had the usual complications, but she engrafted early, and I would say that it was a pleasant experience compared to the other cases. We did try transplant in another young patient aged around 6 years. However, that patient was quite heavily pre-treated and did not mobilize stem cells. So this is the first case. So I think it's getting late, and I'll wind up. With regard to allogenic transplant, it's a donor stem cells. Now the purpose there is, in addition to removing the diseased stem cells using high-dose chemotherapy, you are also introducing donor immunity. So the donated stem cells leukemia affect. So the graft actively hunts for the disease. So that is in addition to the chemotherapy. However, one complication which is more there is graft versus host disease, for which we have to immunosuppress the patient, and invariably this causes increase in infection. So the mortality and morbidity is much more. For autologous transplant, we have not had any peri-transplant mortality, and usually we quote 99% success. But for allo, depending on the indication and type of transplant, the morbidity and mortality is much higher. We hope to do an allogenic transplant this year in our center. We got everything. Thank you very much.
Dr. M. Vijayakumar to please come up to the stage. Thank you, sir. Dr. Achuth Nayak, sir, can we please have you on stage? Thank you, sir. Dr. Senthilnathan. Thank you, sir. Dr. Rajesh Krishna. Thank you, sir. Moving on to the next segment of awarding IMA members for their various achievements, I would like to invite Dr. Pradeep Senapati, who was adjudged the best batsman of the tournament at annual IMA KSB cricket tournament. Thanks.
It's my honor to receive this award from our IMA President and our Secretary. We've been doing very good as a team representing IMA Dakshina Kannada, and we've always tried to notch up a level higher every time we are there on the field. And I think the support what we got from everybody is phenomenal, and we'd like to really replicate the success over the years and also encourage many of y'all to take part in sport and be a sport. So that's what we want to send the message across. Thank you very much.
I would now like to invite Dr. Raghavendra B.S. Sir has made the debut direction for the film Premam Pujyam and has been awarded the Chandravana Critics Award, Times Icon Award, Vishwamanya Award for Kannada Press Council Dubai, and the Honorary Doctorate Film Production and Creativity from KSCI International University, Bali.
Congratulations to Dr. B.S. Raghavendra. He just received the doctorate, honorary doctorate yesterday.
Thank you. Archie sir told me I'll give only 60 seconds to speak. So I have a huge list to thank and dedicate. So I thought I'll cut short. First of all, by ending saying like this, I want to thank myself for working hard. I want to thank myself for never taking off. I want to thank myself for not quitting and all this hard work. And I want to lastly thank my wife for allowing me to speak all this and take credit myself. Thank you so much. Thank you, sir. Thank you very much.
Thank you, sir. Next, I would like to invite Dr. Sheetal Savur for her achievement at the National IMA Racket Sports Tournament organized by IMA Goa. Thank you, ma'am. Can we have Dr. Suhit Ji and Dr. Munawar Ala for their achievement in the National IMA Racket Sports Tournament conducted by IMA Goa? For the achievement in the table tennis. I would now like to hand over to Dr. Achuth for the vote of thanks.
Just before I do that, may I request Dr. Nayak sir to please come over and hand over the books to the IMA President. This is the
actually whatever happening in IMA State Writers Forum, the initiation by Mangalore IMA. 2010 we have started this forum, but in 2012 we started, but we failed to publish the book. But again in 2019 under Sachidanand Rai's leadership, ನಾವಿಲ್ಲಿ ಕನ್ನಡ ವೈದ್ಯ ಬರಹಗಾರರ ಬಳಗನ ಒಂದು ಸಮ್ಮೇಳನ ಮಾಡಿದ್ವಿ. ಅಲ್ಲಿ ತಗೊಂಡ ತೀರ್ಮಾನ ಇವತ್ತು 2 ಪುಸ್ತಕಗಳು ಹೊರಗೆ ಬಂದಿದ್ದಾವೆ. ಒಂದು ಸಿರಿಂಜ್ ಹಿಡಿಯುವ ಕೈ ಪೆನ್ನು ಹಿಡಿದಾಗ ವಿದಿನ್ 2 months ಇಟ್ ಬಿಕಮ್ ಎ ಸೆಕೆಂಡ್ ಮರುಮುದ್ರಣ ಕಂಡಿದೆ. ಆ ಪುಸ್ತಕ ಇದು ರಿಯಲಿ ಇದೆ ಮಂಗಳೂರು IMA ಕ್ರೆಡಿಟ್, ಆ್ಯಕ್ಚುಲಿ ಇನಿಷಿಯೇಷನ್ ಬೈ ಮಂಗಳೂರು IMA. ಮತ್ತೊಂದು ಡಾಕ್ಟರ್ ಸಚ್ಚಿದಾನಂದ ಟೈಮಲ್ಲಿ ಮಾಡಿದ ವೈದ್ಯ ಬರಹಗಾರರ ಬಳಗದ ರಿಪೋರ್ಟ್ ಹಾರ್ಡ್ ಕಾಪಿ ಇವತ್ತು ರಿಲೀಸ್ ಆಗಿದೆ. 5 ವರ್ಷದ ನಂತರ ಸಾಫ್ಟ್ ಕಾಪಿ ರಿಲೀಸ್ ಆಗ್ತಾ ಇತ್ತು. ಹಾರ್ಡ್ ಕಾಪಿ ಮಾಡಿ ಕ್ರೆಡಿಟ್ ಗೋ ಟು IMA ಮ್ಯಾಂಗ್ಳೂರ್. ಆಲ್ ದೀಸ್ ಬುಕ್ಸ್ ನಾನು ಪ್ರೆಸಿಡೆಂಟ್ಗೆ ಹ್ಯಾಂಡ್ ಓವರ್ ಮಾಡ್ತೇನೆ. ಮತ್ತು ಕಾಯಿಲೆಗಳು ಮನೆ ಮಾತು ವೈದ್ಯರ ಕಿವಿ ಮಾತು ಈ ಪುಸ್ತಕ 10 ವರ್ಷದ ಹಿಂದೆ ನಾವು ಪಬ್ಲಿಷ್ ಮಾಡಿದ್ವಿ. ಅದು ಇವತ್ತು ತುಳುವಲ್ಲಿ ಸೀಕ್ ಸಂಕಟ ಇಲ್ಲ ಪಾತಾರ ವೈದ್ಯರನ್ನ ಕಿವಿ ಪಾತಾರ ಅದು ತುಳುಗೆ ಟ್ರಾನ್ಸ್ಲೇಟ್ ಆಗಿ ಸಹ ಬಂದಿದೆ. ಎಲ್ಲ ಕ್ರೆಡಿಟ್ IMA ಮ್ಯಾಂಗ್ಳೂರಿಗೆ ಹೋಗ್ತದೆ. ಬಟ್ IMA ಸ್ಟೇಟ್ ಹಸ್ ಟೇಕನ್ ಇಟ್ ಆಸ್ ಎ ಪ್ರಿವಿಲೇಜ್ ಟು ಹ್ಯಾಂಡ್ ಓವರ್ ಟು ದಿ.
Thank you, sir. I think quickly the events that we had in the last month, other than the CME, we had our CKD CME, which was the CME credits we got from Karnataka Medical Council. It was done in association with Stanley Medical College. So the credit hour certificates is available out to us. IMA Mangalore Women's Doctor Wing is doing a lot of wonderful work. And we have had wonderful talks. We had Dr. Archana delivering the talk on Japanese encephalitis vaccination, and this month we have Dr. Smita Bhatt, who is going to deliver the talk on gender equality. So they're doing a wonderful job. We had the beneficiary check of the IMA KSS scheme that was handed over. In this year we began the IMA quiz weekly. We've had good responses. For the first quiz we have had almost 200 responses, and for the second quiz as of today we have had around 60 responses. We hope to continue this. And about the IMA cricket, I think Pradeep has already spoken. I congratulate the entire team who have participated year after year and kept the spirit going. Blood donation drive was held on Saturday. Venugopal sir was there, and we had a good response. Nearly around 75 units of blood were donated during that. It was held at Katil Pre-University School. The sports events, the 2 upcoming sports events which is going to held in February, we have had the discussion which happened just the other day about the multi CME and the appreciation certificates that we have already discussed. Coming on to the upcoming events, we have a special event coming on Tuesday, that's 17 January. We'll be circulating the details of that soon. We'll have a book release from Dr. Dinakar Rai. We'll be circulating the details very soon. From the women's Dr. Wing, we have the National Girl Child Day, that's 2023, that's celebrated. We have doing the painting competition and essay writing competitions. This is in progress. The February CME is due on 10th February. We'll keep you updated. The 2 main sporting events that we are going to have in February is on the 26th, the Chowdaya M.B. Shetty Memorial Cricket Tournament and the throwball, shot put and the tennis court tournament for the women members. Both of them will be held in Padavu ground. The first meeting as well as the meeting with all the team captains of each of the colleges has occurred. So I request members who are interested to be joining the IMA team. There is an IMA team for the cricket. So members who are interested who have not joined the college teams and others can please join the IMA team. Dr. Nandakishore and Dr. Ranjan are coordinating this. So anything regarding this, please feel to contact them every time. So the feedback link, I think all of you have got. I request you to just put in a feedback and a comment. I know it's been really long. We had promised that we will be keeping before 9:30, but I think today we had a few more additional things to do, so I think we have short time. Other than that, any other constructive feedback, please put it in that. I thank all the speakers today who have agreed and who have come and delivered their lectures today. Special thanks to Dr. Rajesh Krishna who has coordinated this entire thing so smoothly. Special thanks to Yanapa University for having provided the educational grant for today's CME. Thanks to Women Wing, I've already told the quiz. IMA is in the process of upgrading the IMA website. We are planning to do that in the next 1 month, and we have a medicine update regarding hematology that's planned for the 12th of March under the organizing secretary of Dr. Prashant. So it's a full day CME with CME credits, and I think we have requested the IMA state president to be here for that day's inaugural function, and we are planning to launch the IMA website hopefully by that time. I thank the media team. Abbakka TV, Mr. Shashidhar is here. I thank the Kamath caterers who have been there. I thank the entire office team who has been with us. And I thank Dr. Adya, who has been the MC for today and has done a wonderful job for that. I hope I have not missed up anybody for the vote of thanks. We will have the open forum in the next meeting. I request all of you to please stand up for the
Abbakka.